Novel cardiovascular risk factors, markers and makers of cardiovascular disease. We all know that we have the conventional risk factors, right? Look here, 1/3 of the events, coronary events, occur in people who have cholesterol normal level. Less than 200. 1/3 of the events occur. Only in those who are more than 200, 2/3 of the events occur. What should we explain for this one? Look at this one. No risk factor. 19% had coronary event. 43% had one risk factor. 28 two risk factors. And then this is around 17, and then 1% which is 4 risk factors. This is much more common in the Indian context. 30% of the CAD in India occurs without any risk factor. Non-risk factors. You have to diabetes, dyslipidemia, obesity, abdominal obesity, smoking, whatever it is. It is an heart attack. See many a time. What's the reason? 60% have what? Only one risk factor. Remember, risk factors are not diseases. Risk factors are risk factors. They have been modified. Okay? But one risk factor around 60%. This is very common in the young. So when young individual gets a myocardial infarction, they don't get many risk factors. They are healthy. There's something else which is working. Can we pick that up? Cardio-metabolic risks are not supposed to be evaluated. CAD is multifactorial. Tuberculosis, mycobacterium tuberculosis, one organism, one disease, one cause, you know you take it, whatever directly. Coronary artery disease, no one cause. So you drop around. Cholesterol responsible, is it abdominal obesity, is it hypertension, is it smoking habit, and whatnot. If you don't know a thing, you need to search more and more. You need to find out ways of identifying that particular problem. Right? The more we do not know, the more we will search for this fact. No single cause. Early detection, as is emphasized, is meaningful. Because we have interventions today. If we detect somebody early with a higher risk, we can put him to preventive strategy or sometimes curative strategy, depending on where he sits. We have meaningful interventions. That's why risk finding is very important. This is the road. This is very grey area, very heavy, very dark. Nobody notices risk factors, intermediate dysfunction, atherosclerosis until the CAD occurs. Myocardial ischemia, coronary thrombosis, patient is already is ICA, acute myocardial infarction, is in Dr. Damodar's hand, arrhythmia, muscle loss, remodeling, ventricular dilatation, congestive failure, and so on. Why do you allow special connections to go here? Why don't we touch them there? Why don't we do something there? Intervene there, because it is cost effective. It is much more easier, provided you identify. If you wait for them to come and blatantly present with cardiac infarction, they are doing a disservice. They are not identifying the value. They are producing whatever may be the treatment that you give, maybe PCI, maybe CABG, is all carrying. It is not curative. We are bypassing the block. What will happen to the block? It is going to be there, and it is going to be there in the new vessel too. It is going to reach there, unless there is one. This is endothelium. I will tell you. There is a small penetration in the endothelial cells which allows the oxygenation. These are the small penetrations there. This is a normal endothelium. This is an apoptosis endothelium. Endothelium is damaged, the penetration will become wider. There will be endothelium B, endothelial C. To where? To the intima, to the medium. Like which will go, all sorts of inflammatory cells will go, make a havoc. Why does that leak occur? Normal endothelium is the largest paracrine gland of the body. Vasodilatation, thrombolysis, platelet disintegration, anti-proliferation, lipolysis. These are all being maintained in the endothelium by the various factors, particularly as is emphasized by nitric oxide and other factors. This is a normal endothelium functioning normally as a paracrine gland and looking after the health of that gland. So this is the apoptotic endothelium. All the endothelial dysfunction there. Vasoconstriction, Vasodilatation is just a constriction. Thrombolysis is the thrombosis. Addition molecules start coming in. Growth factor, inflammation starts. Both of them. So vasodilatory mechanisms are often vasoconstrictor mechanisms come in. Thrombolysis gives rise to thrombosis. Platelets which are disintegrated start adhering. Anti-proliferation, the same state growth factor. Lipolysis, which is not there, produces inflammation. This is only ABCD here. All those are different. All those are not different. You can start finding out and digging. Whether PI1 is increased or human perspective, alpha is increased, or PG is increased, or R1 is increased, or endothelin 1 is increased, or 2 is increased. No matter what you do, what are you trying to find out? You are trying to find out endothelial integration, the vascular damage. Okay? Now, how best we can arrive at that? Endothelial dysfunction is a common soil for all the diseases. Be it CAD, CAD, CKD, CVD, whatever it is. The common soil is endothelial dysfunction. Just I'll take you through very quickly about that. This is the vascular level, this is the endothelium, this is the endothelial barrier. Nitric oxide is policing here so that nobody enters inside. That policing, if it is absent, all unwanted fellows like LDL can make way inside. How can it get inside? By oxidation. Lipoprotein oxidation. Aggregate. Pyrolysis of this mechanism. Chemical modification. LDL. It becomes a modified LDL, also called OX-LDL, or oxidized LDL. The fundamental step is oxidized LDL. LDL becomes oxidized and enters into the schema of the bladder. This is a modified LDL, slow inflammation. This is not a simple molecule. It is a very dangerous molecule. Oxidized LDL. Now what does it do? It attracts monocyte chemotoxic protein 1, MCP1. This MCP1 is pulling monocyte chemotoxic. Monocytes which are going in the vascular system and the blood are brought inside, inviting oxidized LDL to the intestine. And that monocyte that comes in gets converted into a macrophage. This macrophage, modified LDL, promotes the differences among monocytes into macrophage, and these macrophages start swallowing the LDL and become foam cells. And these macrophages excite cytokines. These cytokines again go and attract various addition molecules are produced to attract further cells. So the inflammation starts. Once oxidized LDL are gone, LDL are gone because endothelial policing is missed. And once the LDL has gone, it becomes oxidized. Once it is modified, it produces MCP1, monocyte attractive protein. MCP1 attracts more monocytes. These monocytes are converted into macrophages. Macrophages excite cytokines. Cytokines produce further chemokines which attract different cells and bring them inside and they start playing cricket in the intestine. Okay? Now, these are addition molecules. VCAM is vascular cell addition molecule. ICAM is intracellular addition molecule. E-selectin, these are all different molecules. Now, these macrophages after swallowing more and more of LDL becomes bloated, foam cell. And that foam cell, again, once first starts releasing the clot, forming the clot, start the damage. So, growth factors are started. After and degeneration, it becomes the seat of clot. That clot has got how then showed us how to measure that clot during the procedure called the CMIT or the oculist. Not only LDL, remnant protein like VLDL remnant, LDL remnant, chylomicron remnant, they also work in the same part. LDL is more dangerous. These are also equally dangerous. They can only get in. Once they get in, they produce similar habits. Now, we all know this slide contains information which we know. Non-modifiable, modifiable, established or conventional cardiovascular risk factors. Age, gender, ethnicity, damage, PAD, phenotype, type A person, diabetes, insulin, hyperlipidemia, hypertension, smoking, metabolic syndrome, obesity, physical inactivity. It can be modified. These have no control. It's all we know. I'm not going to talk about it. For a change. Usually I talk about it. For a change I am not. Now, these are very important diseases, systemic diseases that give you an idea that this person is having cardio-metabolic. the high cardio-metabolic. What are those diseases? You should remember non-alcoholic fatty liver disease. Liver is the window to the heart. This is the caption of the Lancet article. Liver is the window to the heart. Non-alcoholic fatty liver disease, obstructive sleep apnea syndrome, polycystic ovarian syndrome, gestational diabetes, pregnancy-induced hypertension, PAD, CKD, CVD, retinopathy, all are markers of cardiovascular risk. If you see any one of them, you have to look for all the factors. ஒரு ரூம்ல கரண்ட் போச்சுன்னா மற்ற ரூம்ல செக் பண்ணணும். நம்ம வீட்டில் கரண்ட் போச்சுன்னா எது வீட்டில் இருந்தா ஒன்றா செக் பண்ணணும். பிகாஸ் அவங்க கூட போச்சு நம்ம ஹேப்பி. அதே மாதிரி. So when you see these things, you have to look for other things. That's why these are not actually cardiovascular risk markers, but these are the ones which provoke you to look for cardiovascular. Don't ignore. If fatty liver report, என்ன report கொடுத்துருங்க ultrasound. ஒன்றும் இல்லை, fatty liver தான். That is the thing. Fatty liver is a marker of cardiovascular disease. If you miss that, liverல cancer இல்லைன்னா போதுமா? liverல fatty liver இருந்தால் அது disease கிடையாது. ஈஸி வயசு தான் இருக்கு, ஒன்றும் இல்லை, பொண்ணுக்கு நல்லாவே இருக்கு, ரெண்டு ஒரு சிஸ்டிக் கட்டிருக்கோம். That is a marker of cardiovascular disease. So you have to pick them up and then start working on them. Now, advanced investigations like TIMC, pulse velocity, promeditation, difference, non-difference, intravascular ultrasound, myocardial not in the mind and the general system. Special cardiologist, difference. They do it and they are of course that's good. I am not going to dwell on those. UL markers, experimental ones, C-peptide as a measure of CV risk. C-peptide as a measure of diabetes is different. C-peptide as a measure of CV risk. Uric acid, fibrinogen, PA1, PI1, inflammatory markers, GCAM, ICAM, serum amyloid alpha, interleukin 6, metalloproteases, subtractions of LDL HDL, all are there, but they are experimental. In future time, probably after 10 years, 15 years, we will looking at them and say, okay, this guy has got HCAM more, so probably he is higher. Or this guy has got SCAM more. So, talking about that after 10 years, not now. Now, the novel risk makers, risk marker and the risk maker. The one which paves way for the disease is a risk maker. The one which marks the disease indirectly is a marker. Marker is not causative. Maker is causative. That's why Hs-CRP, LPA, SLDL, high PG molecules, endothelial dysfunction, Apo B A1 ratio, ApoC3, please note this very carefully. Latest information shows ApoC3 levels are directly correlating with cardiovascular. What is ApoC3? ApoC3 is a scavenger protein. It sets the LDL from the circulation. Whatever LDL that comes to the liver should get excreted. For that ApoC3 is required. Suppose ApoC3 is missing, LDL will not get it. It gets it. So today, slowly we are moving from Apo B A1 to ApoC3 also. Probably in future time, ApoC3 will be a good marker. I won't dwell on many of these things in this lecture, except that I look at Hs-CRP, LPA, maybe a little more on endothelial function. And one or two right now. I'm not going to show many of those other things which I have listed. Now the most important clinical marker, forget about all these things. I don't want all the big tests and all that, which are not established. I want something clinical. Tell me, how can I pick a person who is walking into my room that he has got cardio-metabolic? What is the very which stage? When did he use it last? Why did he not measure the waist? What waist circumference is an important marker of metabolic syndrome and cardio. Nobody bothers to put that. They want CCAM, SCA and all those. They are interested in doing simple things, making things simple. Microalbuminuria test which costs hardly 150 rupees is a wonderful risk marker for cardiovascular disease. It is the way the endothelium beams through the kidney that it is affected. Microalbuminuria is a wonderful risk marker. ABI, ankle breaking index, checking for the pedal pulse for all the patients. If I don't touch the foot of the patient, I'm a bad doctor. God won't bless me. But 2 days is had that. One for the pulse, other for the symptom. If I don't do that, I'm not a clinician. Every cardiologist physician must do the pedal foot pulse examination. And LVH by echocardiography is a must. LVH independently prescribed. And ask about his sexual life. Endothelial dysfunction is equal to erectile dysfunction. Erectile dysfunction is equal to endothelial dysfunction. ED is equal to ED. What is the endothelial dysfunction? The blood vessels are not able to dilate and engorge the penis. Why are not able to dilate? Because the endothelial is not able to mount nitric acid. It's not dilating. The same thing, the blood vessels are not dilating the heart. What happens? Same thing happens in the penis also. Penis is called the barometer of endothelium. Okay? Pulse pressure is important, particularly hypertension system. I have shown you two important slides as clinicians take. One is this slide where you mark the simpler techniques like WC, MAU, ABI, LBH, GD and all, which don't require magnetic resonance, PET, or don't require going to a backward. Very simple. The other thing is that diseases which could mimic cardiovascular disease, like the NAFLD, the PCOS, the obstructive sleep apnea, these two are the clinical ways of identifying endogenous cardiovascular. Apart from your conventional risk factors of diabetes, hypertension, dyslipidemia, obesity, plus that slide and this slide is the take home. The remaining things are only for discussion in this room. Leave them here, don't take them. Okay. Look at CRP. CRP is doing, Hs-CRP is doing a wonderful information for us. Hs-CRP and LDL-C measurements are done. Those who have low CRP, low LDL, good survival. Those who have high CRP, high LDL, worse survival. So high CRP, low LDL are here, low CRP, high LDL are. So we need to say that those who have CRP and as well as LDL, they do worse compared to those who have low CRP and low LDL. This is now established fact. CRP is a very strong risk marker of heart attack. And it is in fact, I see the other slide, which is that it is accepted now to this degree. Now you see, CRP is less than 3, no metabolic syndrome, good survey. CRP is more than 3, there is already metabolic syndrome, bad. That means there are clustered risk factors associated with CRP. That means like I showed you, LDL plus CRP, here metabolic syndrome plus CRP. Okay, anyway you look at it, CRP is contributing to your information that this fellow is moving from a intermediate risk to high risk or moderate risk, I mean low risk to intermediate. Just like I showed now, by changing the age, chronological age to his age that is worked out, how the risk change. This CRP will add information for you to move the patient across the strata and then decide whether they require any intervention at that point. Now, look at different ones, lipoproteinemia, homocysteine, interleukin, total cholesterol, LDL, CCAM, serum amyloid alpha, Apo B, total cholesterol, HDL cholesterol ratio, Hs-CRP plus this ratio. It is doing a wonderful job in terms of relative risk prediction. Compared to all these things, if you do Hs-CRP and take the levels of cholesterol into account, combine that information, you are going to get a better information about the disease. Now, this is an article in the published in Circulation 2003, C-reactive protein, the metabolic syndrome, the risk of infinite coronary event, ATR power study has shown that CRP can be used as a good marker. Later, the operator disappeared, Wall Street Journal, heart gets major patients after a batting heart reconstruction end of this is about Hs-CRP. Now, American Heart Association changed the scientific statement 2003. Measurement of Hs-CRP is an independent marker of risk. Maybe you at the distance which is a part of global coronary risk assessment. That is without known coronary artery disease. Weight of evidence are used particularly among those cases the intermediate risk by global risk. If the patient is Bio-Cunningham score or whatever score you adopt is in the intermediate risk, if you do a Hs-CRP, you can keep them in that risk category or move them into a higher. The Hs-CRP is normal, it stays in that category. Hs-CRP is higher, it moves to the higher. There is a very low risk category, Hs-CRP will not be very useful. For a very high risk category, already established second it does not use. Because there already the answer is no. He is having already suffering the disease. Okay? Now, what of the cutoff value? This is different from the routine CRP you do for your joint or other mistakes. Anything less than 10. Only we take more than 10 is because of the acute phase response of arthritis or fever or allergy. 1 milligram, low risk less than 1, 1 to 3 moderate risk, 3 to 10 high. So do a Hs-CRP, less than 1 low risk, 1 to 3 moderate risk, don't less than high. 3 to 10 higher. More than 10, it is not due to the heart problem, not due to CV. It is due to some other acute phase problem. Now this shows if the total cholesterol and the HDL ratio combined, the total cholesterol is more, the risk is more. Like if the Hs-CRP is more, the risk is more. If both are more, the risk is more. So the again combining the cholesterol information with Hs-CRP is going to be used. And you can see a normal, this is Hs-CRP level and enhanced by overweight individuals obviously, obesity also correlates with Hs-CRP. This is a beautiful slide. Quartiles of Hs-CRP, risk of cardiovascular death, first quartile very low Hs-CRP, fourth quartile very high Hs-CRP, and then increment. You see non-cardiovascular death, whatever may be the quartile. So Hs-CRP is a direct marker of cardiovascular mortality. So this slide, the second part of the information is non-cardiovascular death, Hs-CRP quartiles are same. There is no increment. Here, the more the quartile from 1 to 4, there is a jump in the cardiovascular. So Hs-CRP is a good marker for cardiovascular disease. Maybe you can think of using that. LPA in Indians particularly is important. Small LDL molecule Apo B protein like thing with associated double bond. Normal value 20 milligrams, more than 30 high risk. You don't have to do every time because it won't change much. If you do once LPA, it's probably adequate. You know whether the person is very heavy LPA. So you see again, there is this LPA eliminated associated with other factors. As you have more factors added, more is the higher result. Now, atherogenic particles, the remnant, we call the remnant, so-called, once the cholesterol is depleted from these things, they become the remnant. When the PG-rich proteins are there, these PG-rich proteins today are considered very heterogenic. Earlier days, only we were concentrating on the LDL and the SLDL. Now the PG-rich proteins also are important markers for endothelial dysfunction, your hypertension, diabetes, smoking, LDL, homocysteine, estrogen, all increase the oxygen secretion there, protein increase, endothelial cells, loss of NO is decreased, endothelial dysfunction starts, apoptosis, leukocyte adhesion, lipodeposition, proper constriction, growth of close muscle thrombosis, even which we have already seen in that slide. Now, prediction of endothelial dysfunction, if you do a relative risk of dysfunction, but the normal function, those are dysfunction. In all the studies, endothelial dysfunction has shown a higher future coronary vascular or cardiovascular disease. Those that have more of endothelial dysfunction are more prone for cardiovascular disease. Now, the inter-heart study said Apo A1 by B, the greater the Apo A1 by B ratio, that means more Apo B, which is atherogenic protein, Apo E is less, the ratio will be more. More the ratio, the more it is. The other thing that you can think of measuring properly. One is Hs-CRP, one is LPA, one is Apo B by A1. I asked about homocysteine 10 years ago. Now homocysteine we don't know whether it is the effect of the disease or the cause of the disease or the marker of the disease or the maker of the disease. Incidentally you find somebody with hyperhomocysteinemia of the range of around 31 or 100 or more than 100, and you give them folate and reduce it for whatever it is worth. But the conclusive answer is not yet written about homocysteinemia. This is the step I am talking about intra-abdominal fat and the don't forget about that. This is a beautiful slide to tell you that low BMI, normal weight, one is that. High BMI, high weight, 16 is that. BMI normal, but waist is more, waist is less, but the BMI is more. What this says is more than the weight, it is the waist that is more. Both are important. Better to have ideal weight as well as ideal weight. Between the two, abdominal fat, abdominal circumference is greater than. Ankle breaker index, none of us do it. The temperature that everyone starts looking at the parent first and doing the ankle breaker index. Anything less than 0.9 is called peripheral vascular disease. 0.8 to 0.84 is claudication less than 0.6. Critical limb ischemia. Always check the parent first. And question for intermittent choice. Simple question. In the bus stand, I go walk on 1 kilometer. Nearing a place. Temple place. Particular immunity for man and face said, sir, when you follow for an expert, all over it is particularly again. And after the period, I am able to. That is what is called intermittent choice. that is there, that symptom. It is indicated. Every diabetic, every smoker, every patient of cardiovascular disease, other cardiovascular disease, must get an ankle brain test. Not a very difficult test at all. It can be done by the bed, at the bed. So you see here, the beauty of this particular thing is, if the ankle breaker index is less than 9, okay, very specific of cardiovascular. But if it is normal, it cannot rule out the disease. Ankle breaker index of normal nature does not exclude peripheral arterial disease. Ankle breaker index of reduced nature of less than 0.9 pinpoints the disease. It confirms the disease. It is a specific test, not a sensitive. You understand what is sensitive test? So it's a very specific test. Somebody is positive for ABI, that is less than 0.9, specific for PA. Microalbuminuria, I have been talking 30 to 300 milligrams of microalbumin per unit in 24 hours. Most accurate assessment 24 hour collection, but cumbersome. But spot can be done. Spot between 30 and 10 okay. Regression of MAU decreases the CV risk. Marker of generalized CV. It doesn't talk about kidney alone. It talks about generalized CV. The relative importance. This is your cholesterol and this is your microalbumin. High cholesterol, this is the risk. High microalbumin risk. Okay? This is not enough evidence to say that we should do microalbuminuria in every patient of cardiovascular. It is an important thing. You should not forget doing it. There will be thickness to the left ventricle, normal being less than 10 mm, 26 millimeters. And LVH is an independent predictor. Men and women, no LVH. LVH in this color, no LVH left side. This is incremental risk. Both to the CHB and the both the units. Now there are new factors, so many new factors. These measure arterial or venous thrombosis. Venous thrombosis, these won't work. Arterial thrombosis, they can pick up. For example, fibrinogen, factor 8, 1 millibrand antigen, PPA, PA1 antigen, platelet function, LPA, Hs-CRP, serum alpha, interleukin 6, human factor alpha. All these things tell about arterial health. They don't talk about the venous. There are certain factors which talk about the venous health, factor 5 laden, prothrombin mutation, prothrombin, factor 8, antithrombin 3, protein C, protein S, homocysteine, D-dimer. They talk of venous health. D-dimer and homocysteine, they talk of these factors that are want to investigate. Now, some of them are specific for venous disease, some of them are specific for arterial disease. Now, this is an important paper which is published by the AACC, American Association of Clinical Chemistry. This is summary for that. You can pinpoint using these things what is the status of the blood vessel. Atherosclerotic plaque formation. That is the earliest thing, isn't it? LDL, SLDL, oxidized LDL, remnants of the lipoprotein, CRP, interleukin 6, can 18 km of the plaque. These tell about the plaque. Inflammation of the atherosclerotic plaque. Okay, plaque is there. Is that plaque inflamed or sleeping? The plaque is sleeping, no problem. But inflamed and rupturing only is the plaque. How do we know that? By doing CRP, MPO, this is myeloperoxidase, metalloproteases, soluble CD40 ligand. That is called lymphocyte. The CD40 is the T lymphocyte. CD40S, CD40L ligand. These are markers of inflammation of the atherosclerotic plaque. Then you go to the vulnerable plaque imminent for rupture. Can we say that the plaque is about to rupture? Yes, there are techniques now, MPO, MPP and MMP. MPO is metalloprotein and this is the MMP is metalloproteases. This is the oxidase enzyme and this is PAPP is pregnancy associated plasma protein A. It is called PAPP. CGF, cell-derived growth factor, ICAM, BCAM. These will tell you about imminent rupture. So now they have moved from atherosclerotic plaque formation, inflammation of the atherosclerotic plaque, vulnerable plaque, it is about the rupture. Now, suspected platelet activation and thrombosis, some sort of fighting going on in the plaque and around the plaque. And that is increasing levels of lymphocyte CD40, PA1, that is plasminogen activator inhibitor 1 milligram factor, D-dimer. These tell about the thrombosis going on. Myocardial ischemia mediated albumin. fatty acid binding protein. These will tell about myocardial ischemia, choline and BNP also. Myocardial necrosis we all know, Prof I and Prof T, CPK, CPKMD, myoglobin, BNP and metabolic. So this is a nice paper which segregates you right from the atherosclerotic clot formation to the inflammation to the value of vulnerable clot rupture and then of course suspected thrombosis, myocardial ischemia and myocardial. Now, the science is going so fast that the day will come, okay, this will have got clot, this will have got an active, inflammatory clot, this will have got a clot about the rupture, this will have got a clot where the thrombosis is going on. Here there is already the thrombosis is giving way to ischemia. And this is a place where by looking at it. But there's a aura, take time. But these are being worked out. You see nicely it is unfolding. From the side there is atherosclerosis, down to myocardial infarction. By doing different novel facts, one can pinpoint some point in time in the future, probably within. You see, some there in the heart, there in the vessel wall, there in the macrophages, into the adipose tissue like leptin and adiponectin, and things there in the liver like Hs-CRP, fibrinogen, selenamide alpha, and different cytokines which are excited by these things into the blood. All could be potential cardiovascular risk marker of tomorrow. Now, multi-marker approach has started. Instead of doing one marker, why don't you look at multiple markers like Hs-CRP, CD4A, ligand, troponin, NT-proBNP, BNP, chromium chloride, microalbuminuria, HbA1c, blood glucose, all put together, put them into a number, and they'll say, come with a multi-marker. You don't give a number, whether the person has high risk or intermediate risk. This is also being worked out. And this type is a biomarker in this Morgan cohort. Lipid markers, renal function markers, cystatin, creatinine, metabolic markers, adiponectin, leptin, insulin, ferritin, and glucose, coagulation markers, heterogenesis markers, necrosis markers, markers of oxidative stress, markers of inflammation, markers of vascular function. So many markers are being studied, but none is ready to be clinically applied as. Now you see, so many, can't even read, so many number of markers are being studied with plus minus. Only the Hs-CRP, NT-proBNP, troponin ions are consistently predict the field. As on date, the concluding thing is Hs-CRP is one test. It's sure you can use it in clinical hospital. Maybe in Indian scenario, LPA and also Apo B ratio also can be used very much. All other things are still in the stage of development. We can't say experimental. A lot of evidence is there. A lot of follow-up studies are required to correlate this. Conclude. Conventional risk factors do not predict global risk well. That way all this works. The conventional risk factors are accounting for all the 100% of the cases of myocardial infarction or other cardiovascular disease, like your hypertension, diabetes, dyslipidemia. Then you don't require such for use. Because there is a hollow, because there is a gap, you need to look for new risk factors. Measurement of certain biomarkers such as Hs-CRP may be useful in conjunction with other risk factors. Insufficient data at the present time to recommend novel biomarkers to screen the population at large, but in selected intermediate risk group, they may be appropriate. If a person is in the intermediate risk category, whether to intervene or not to intervene, the dilemma will come. The coronary is 40, 50, 60%, risk level by estimate intermediate procedure will be offering something or not. Unless additional risk factors come into play, shift the patient either there, keep them there, or shift them to the higher category. So that you will be able to decide on. Individual biomarkers do not markedly improve the risk assessment. None of these are ready for day-to-day clinical application except Hs-CRP, probably LPA, and Apo B A1 ratio. Cost effectiveness of these tests and outcome studies that they should correlate with the real event, other events are required. Until then, they will keep them as science and not use them as clinical medicine. Science is different. Science is developing science and not as clinical. Now, this is the iceberg I picked up in Alaska on picture. Lot of ice is there underneath, not see. The visible coronary artery disease is only visible. Only non-visible cardiovascular disease. Even the visible disease, lot of havoc. You don't know anything about that. Only 30%, 40%, 50% we know. The remaining 30, 40, 50% we in that. How is this picture nicely explained the halo of the gap in the knowledge. Any questions? It's a CRP. CRP, C-reactive protein. Can you tell me why it is called CRP? Anyone of you? Anyone of you? Subject matter. Why it is called CRP? And originally, this protein is getting attached to the Clostridium difficile. This is called CRP. C-reactive protein. It is reacting with the C antigen of the particular RNA. That is why it is called CRP. After that it started coming into CRP. It is a CRP. So that is the reason. Now, Hs-CRP is high sensitivity CRP. Normal sensitivity CRP cannot estimate 1 milligram, 2 milligram, 10 milligram. 300, 400, 150 is the estimate. That Hs is no use because our cardiac risk values are less than 10. If it is 20, 300, 400, result is there, it's a joint estimation of number fever or something to make it. Acute phase reaction. They are not worried about that. That's why we don't order for ordinary CRP in this case. We ask for high sensitivity CRP, where the assay picks up even minor quantities of CRP. So that will be between 1 to 10. 1 less than 1 is normal, 1 to 3 intermediate, 3 to 10 is high. More than 10, not due to high. Ask the fitness here. Maybe 250 is a good app. Not very expensive. I do it for them. I do LPA, I do Hs-CRP, I do Apo A1, B by A. And I do all the clinical things I do. The WC, and then the looking for all the other diseases, what they can actually. If the value is higher, it's indicated that you repeat it after 2 weeks. If the value is very high, like 200, and then you know it is not good. So if it is normal, you generally do it. And make sure that the patient doesn't have any acute infection during the time of surgery. Supposing you are having fever and you wanted to Hs-CRP, it may not be due to your heart.